So, good morning, everyone. This is Angela Knight. I'm from the Office of the CIO, and I'll be monitoring the WebEx today. So, thank you for joining us for the webinar on contact tracing in Washington State, and it's presented by Chief Privacy Officer Katie Ruckel. I just want to remind everyone that this session is being recorded, and I'll be monitoring the chat box throughout the presentation. So if you have a question, please add it there, and we'll see if we have time at the end to get to questions. It might run a little bit long. I also wanted to let everyone know that after the session, I'll be sending the slide deck out to everyone who was on the meeting invitation. And so with that, I'll go ahead and turn it over to Katie.
Thanks, Angela. Can you hear me?
Yes, I can.
Great. So if you could go to the next slide. I'm Katie Ruckel, just a reminder for everybody, the state's Chief Privacy Officer, and I have a lot of information to share with you today. So I'm just going to briefly go over the overview of what I'll be covering. I'm going to talk about case investigation, contact tracing, and exposure notification, and those concepts as we discuss them in the public health context, and what technologies the state's using in terms of approaching the pandemic and how we're handling the information collected. And then what information is collected for what purposes, some privacy considerations regarding public health surveillance, and then I'll wrap it up with legislation that's looking at legislating some of these areas, especially in data collection and apps. So for defining case investigation, contact tracing, exposure notification, I was able to talk to an epidemiologist about these concepts, and I had originally been thinking of them as distinct, and we would be discussing the differences between them, but he helped me understand that they're really interrelated and overlap each other. And so while there's a broader public health surveillance effort, contact tracing and case investigation are fairly similar, and they all stem from exposure notification as well. So I'm going to get into those concepts. Next slide. Some of the definitions that we'll be talking about today is that a confirmed case is somebody that's actually had a laboratory positive result, and a contact is someone that's been within 6 feet of someone that's infected for at least 15 minutes. I think some of the definition of contacts may differ throughout the country, but I've seen it as low as a 6-minute exposure, but in Washington right now we're just, we consider it to be 15 minutes. And then case investigation is when there's an actual confirmed case. And the difference with that and contact tracing is somebody that's had contact with a confirmed case. So that's the distinction between those two concepts. And for today, exposure notification, I'm really going to be talking about that in terms of how we use that term regarding apps that might be downloaded to smart devices. So contact tracing is the process of identifying people who may have come into contact with an infected person. And it's really a traditional method of public health surveillance that officials use to track and spread infectious diseases within a population. And that's been a method used for decades. We're just hearing about it a lot now in popular conversations and media attention because it's affecting all of us in our daily lives. And so public health officials or contact tracers contact, so that's going to be contact in a verb, potential contacts as a noun, about possible exposure and collection of information that helps determine if a contact is a potential case, which is somebody that is confirmed to have the infectious disease. So one term in here that I want to focus in on really quickly is the use of the word surveillance. Next slide. So public health officials are very, very comfortable using the word surveillance. And when we're talking about that term for population health, they're just talking about in terms of monitoring the public health. So people in the public, though, may be alarmed to hear this term as it might conjure up images of government surveillance and spying. But I want to just be clear that on the next slide, we're not talking about spying on people. We're talking about population health. So in the scientific method of surveillance is how we'll be talking about surveillance today. So I just wanted to raise that awareness because it's used very frequently among epidemiologists and scientists in terms of monitoring and surveilling the public in terms of population health. So an example of contact tracing is, this is a diagram from a contact tracing training that the Department of Health has, and their training goes into depth on all of these potential contacts, but I just wanted to go through really quickly the type of activity that occurs. So if you see for number one, there's a known case, and that person would tell a case investigator or contact tracer about people that they had contact with. And so that would be 2, 3, 4, and 5. And here we see that 2 and 3 may have had contact with an infectious person, but they're not displaying symptoms, but 4 and 5 are displaying symptoms. And so the 2 and 3 are told to quarantine, and 4 or 5 are told to isolate. And so I'm going to talk about the difference between quarantine and isolation quickly. But I do want to point out that as part of this exercise, the individuals who are contacted are not told the identity of who the known case was in order to protect confidentiality. So the difference between isolation and quarantine is that if somebody is actually tested positive and even maybe asymptomatic, which means they're not displaying symptoms, they're told to stay away from others to help stop the spread of the infection. For people that have been exposed, they are just told to stay away and monitor their symptoms. So a distinction is that the governor's order has sometimes been called a quarantine order, but it's not actually a quarantine order or an isolation order. It's an order to help people social distance and restrict their movement so that we're diminishing impacts for spreading the virus. So the next slide, I have a little bit more information about what people are told in terms of isolation and quarantine. So if you actually have confirmed a case, which is when you're told to isolate, you have to be fever-free at least 3 days without medications, and then not display symptoms for 10 days since the symptoms began. And then you need to, if you're going to quarantine, you just stay home for 14 days after the last exposure to an ill person. But if your symptoms develop and or become positive, then that kind of puts you back up into the isolation area. So when we're talking about isolation and quarantine, it's helpful to understand these differences. So for a contact tracer, they are contacting people within 48 hours of a lab case, and then they're notifying the people that may be exposed, and they ask several questions. I have slides later about some of the specific information that they're gathering, but this is just a reminder that a contact is going to be somebody that has been with an infected person for at least 15 minutes, a couple days before the onset of symptoms. Case investigation is a little bit different from the contact tracing because it involves the process of investigating a potential source of an outbreak. So in normal times, before there was a pandemic, almost all case investigation and contact tracing was done by epidemiologists or professional public health employees. However, because of the spread of the epidemic, case investigation and contact tracing has had to be shared with a lot more people. And so that's why we've had a lot of volunteers hired to help with the contact tracing that's happening, although the case investigation is, for the most part, being done by the epidemiologists. So another part of the investigation that happens is that there's been some discussion between respiratory droplet transmission versus fomite transmission. And just for reference, fomite transmission is when the virus is on objects like doorknobs or elevator buttons. And the most recent research that I've seen on this is that the virus is less likely to transmit through fomites, but it's not impossible. And so that's why there's so much emphasis, especially on hand washing and disinfecting, and being careful not to touch your eyes, nose, mouth, face in terms of transmitting the virus. However, the virus transmits mostly through the research that's been done through contact with individuals. So case investigators are actually getting the lab results from the doctors and labs, and they're mandated to report these conditions under Washington law. So the lab results go into a system called the Washington Disease Reporting System, and that information is input and shared with public health, including the Department of Health and the local health jurisdictions, which is what the LHJ stands for. So when they're doing the case investigations, they're reaching out to individuals for positive health results within 24 hours to do the investigation, which I'm going to get into more of those details. So exposure notification, I was talking to the epidemiologist yesterday, and he kind of explained to me that this term has been turned on its head a little bit for public health officials, because traditionally exposure notification was happening with the contact tracers when they were reaching out to individuals to let them know they've been exposed. But in terms of what we're talking about with the apps that might be downloaded to smartphones, we're talking about people getting notified of potential exposure before they even have contact with a public health official. And so there's been an effort to change the names of the apps. They've been referred to as contact tracing apps, but what they're really trying to do is call them exposure notification apps, because the contact tracing apps are not meant to replace the contact tracers that are being hired to manually contact individuals. The exposure notification apps are just a way to help people be put on notice that they may have been potentially impacted, and then the app would give some sort of direction of what the person should do when they've been potentially exposed. So this is more resources about all of the concepts that I've been talking about, and I have included links in the presentation and this infographic from Department of Health to kind of boil it down in a simpler way about contact tracing and case investigation. But there is a lot of information out there about all of these efforts, and including more information about the exposure notification API that I'm going to talk about in a little bit. So you'll receive these slides after the presentation today if you're interested in digging into some more details on these concepts. So next I want to talk about some of the technologies that are being considered or used to assist the state's effort to combat the pandemic. This is a lot of logos of some of the technologies that are being used. So if you go to the next slide, this is meant to sort of be an overview of where we're at. So I wanted to point out the ones with the crosses through. So originally for the apps that are being considered in Washington, they originally named it COVID Safe, and it turns out that Australia already had a COVID Safe. And so Washington moved away from that name, and so they're no longer using COVID Safe to describe the app. They're using Common Circle, which is up there with a question mark over it. And I put a question mark for now because no decisions have been made about a use of app in Washington, but it is being strongly researched and developed. And so at this time, I'm just going to put it as a question mark. For the other areas that other technologies, the Sarah Alert, Microsoft Dynamics, and RedCap are all types of technologies that I'm going to talk about a little bit more in terms of how that's being used for contact tracing and case investigation. But the Washington Disease Reporting System has been around for years, and that's what's used in all counties right now in terms of collecting information on infectious diseases, including COVID-19. So RedCap, Microsoft Dynamics CRM, and Sarah Alert are all technologies that are being used in some counties, but not all. So the Washington Disease Reporting System that I've been talking about is actually the disease surveillance system that allows the public health staff in Washington to receive, enter, manage, process, track, and analyze the disease-related data. And this information comes from healthcare providers, hospitals, clinics, labs, and would be considered the protected health information that the Department of Health is receiving from public health entities. And it also is a secure database that only the public health officials have access to. RedCap was brought in to help collect information, especially for some of the larger counties, in terms of part of the COVID-19 contact tracing efforts. And it's a web-based application built by Vanderbilt. However, the use of this software ended up not being quite what the state needed. And so while it's still being used in some parts of the state, we're really moving more towards the use of the Microsoft Dynamics platform, which is the next slide. Or sorry, Sarah Alert is the next one. So Sarah Alert was also an early system that was adopted in terms of helping people be notified for symptom monitoring. And this is used by the contact tracers and case investigators to help people monitor their symptoms. So this is not actually an app that's downloaded, but it is a system that's used to follow up with people regarding symptoms and then determine whether or not they need to be further contacted by healthcare professionals or epidemiologists regarding the spread of the escalation of the disease if they have it. So part of what Sarah Alert does is people have the option, if they've tested positive, to be contacted by phone, text, or email in terms of monitoring their symptoms. And this is something that is used in concert with RedCap as well. Several states are using that as well, including Vermont, Pennsylvania, Idaho, and Arkansas. The Microsoft Dynamics platform is one of the newest technologies that the state has adopted, and the system that DOH is calling it is CREST, which stands for the Case, Risk, and Exposure Surveillance Tool. So there's that word surveillance again. So, and this is the software that's being used by the contract tracers, including the local health jurisdictions and epidemiologists, although it's not quite available everywhere yet. they're looking to expand the use of this platform, especially given the volume of case monitoring that needs to occur for the pandemic. And one thing I wanted to point out is I think I've heard some confusion with Microsoft Dynamics CREST platform with the actual app, the Common Circle app. And I wanted to point out, I think there's been some confusion because they've both been talked about and looked at adoption at the same time, but the CREST platform is not the same as the app that's being developed. So the Common Circle app, this is the Washington's exposure notification app that's being developed with UW Medicine and the UW Computer Science School and Engineering. And this is the one that I think is getting a lot of press and attention, or these types of apps, because of the nature of them being on people's personal devices and potentially collecting health information. So no decisions have been made yet in Washington in terms of the adoption of this, but it is being thoroughly researched and looked into, and it's going to be a voluntary app that people can download. It's using the Google Apple application programming interface, and then it's being developed with UW and Microsoft volunteers. So this was the beta testing that was occurring was that I last saw was with COVID Safe. So I haven't seen the beta testing for the Common Circle yet. But one thing to note is that there is a state oversight team that is reviewing the possible adoption of this technology. And oh, I'm getting a comment here. To determine the feasibility. So there hasn't been decisions about adoption made yet, but it is being heavily researched and reviewed. So what data is being collected for which purpose? So for what purpose? This really depends on the purpose for the collection, whether you're doing contact tracing, case investigation, or exposure notification. So public health data is collected to support the health of the public through community health assessment, identifying new or emerging pathogens, disaster emergency preparedness, environmental health or outbreak surveillance and response. And it can contain, as I talked about, protected health information and other sensitive health information, and which includes possibly very sensitive information about individuals. But the information collected for contact tracing, if you could go to the next slide, Angela, is somewhat higher level than what's collected for case investigations, but it includes people's name, phone number, email, demographics, including age, date of birth, and primary language, health information, whether or not you're displaying symptoms or have been tested for COVID, and then what resource needs you may need, including isolation and quarantine guidance. If the contact that the contact tracer reaches actually has symptoms, then a lot more information is gathered about where they've been and that type of information, which gets closer to what the case investigators are doing, which is the next slide. So for case investigations, as I talked about, the case investigations are actually our positive people that have tested positive. So a lot of times they already have a lot of this information, but they're verifying the home address, phone number, email, the demographics. Especially race and ethnicity has been a hot topic recently because they're trying to really understand some of the disparate impacts of the virus on sub-communities, and so, or subpopulations of the broader population health. So there's more emphasis on collecting some of these demographic data than there had been. I did notice in the WAC that race and ethnicity are not part of what has to be mandated reported by the healthcare providers, which I think is what is possibly creating the gap in some of this information, but I know that everybody's working hard to make sure that they're collecting appropriate demographic information to make sure we're targeting everybody equally in terms of helping to mitigate the impacts of the disease. So health information is also collected, including symptoms, health history, whether or not individuals are admitted to the hospital, and what type of care they received in the hospital, which includes whether or not they were on a ventilator or received oxygen as a part of their care. And then other information that's collected is where the person might have been during the exposure of contagious periods, which includes locations like where you work, places you might have been socially, places of worship, and facilities, including high-risk facilities like long-term nursing facilities or hospitals or jails. Resource needs includes giving further guidance again about isolation and quarantine, and then also gathering information about household members and non-household members in order to do further contact tracing with those individuals. So these are all a lot more specific data elements that are actually asked about through the contact tracing. So I'm not going to go through all of these, but I just wanted to share actual very specific information that may be asked about in terms of understanding the case investigation data that's collected. And that is also true for the next slide that goes into details about employment. And there's a whole list of high-risk facilities that people make sure to case investigators ask about in terms of making sure that if there's a large exposure that people can be properly notified or contacted in terms of tracking the outbreak. And for traveling for out of country and out of state, this is a lot of the contacts for people that fly into the States. A lot of that is done by the CDC instead of Washington State volunteers or employees. And I have a little bubble in the top that actually talks about the scripts that I've seen that the contact tracers and case investigators are using includes these specific elements for each one of these places where a person might have visited. So it could possibly be a lot of information for each one of these in terms of the location, the date, and how long the person was there. For all the information that they collect, I think it is important to understand what case investigators or contact tracers are not collecting. And some of you may recognize this list from the data breach webinar that I gave recently. So these are almost all of the personally identifiable information that people need to be notified of if they're breached, which case investigators are not going to be asking for any type of financial information, account numbers, credit card numbers, passwords, military, passport ID, health ID, social security number. Any of those types of data are not going to be collected by case investigators. They're not needed for tracking the outbreak. In other sensitive things that may be asked, marital status is not relevant and immigration status is not relevant. So those are things that contact tracers or case investigators should not be asking and will not be asking. But one piece that I do want to point out on the next slide is that contact tracers or case investigators may ask details to help people remember where they've been. And so that would include maybe asking somebody to look at their calendar, email, or credit card transaction history. That's really just looking at receipts. to know time and place they've been, where you've been. Not any credit card number or anything like that is needed. It's just used to help people remember where they might have been so that they can track down all the places where there's potential contacts. I did want to note that there are 2 data elements of personally identifiable information that are in that list that public health officials will ask for, and that's date of birth and health information. And so other than that, all of the financial information or social security numbers, ID numbers, that type of thing is not the type of information that is collected. I did have one question about this slide because DOH does collect phone numbers, home addresses, and emails. So just a reminder, those 3 data elements are not actually PII as defined under 4256-590. So while most people would consider your phone number, address, and email to be personally identifiable information, it doesn't fall under the data breach law that would require you to be notified if that information was breached. So it doesn't meet the definition of PII under that law. So that's a subtle distinction, but just wanted to point that out. So next, we're going to talk about some of the privacy considerations in public health surveillance. So because of the nature of the information collected, privacy and confidentiality are cornerstones for public health because the public health suffers if people don't trust that the information is going to be handled confidentially when they're talking to Department of Health or anybody in the healthcare profession. So there are RCWs and WACs that lay the foundation for some of the confidentiality and practices for handling the sensitive information. But one thing that might surprise people is that HIPAA does not actually apply to the protected health information that's provided to DOH for public health purposes. Labs and clinics and healthcare providers and doctors are required by law to provide protected health information to the Department of Health for public health purposes. And so that disclosure is allowed under HIPAA. And while that is considered PHI, the obligations of HIPAA don't follow that data to DOH. However, they are required to keep the information confidential under other laws. And they rely on the Healthcare Information Act and specifically some exemptions in law and their WACs regarding notifiable conditions to protect that data and keep it confidential. And there's a lot of different WACs and responsibilities that DOH has in order to keep protected health information confidential when it's being handled for public health purposes. And then another important consideration in terms of when I write EN, I'm talking about the exposure notification apps, is that data minimization and the limitation of purpose in terms of the information being collected and only used for the purposes it's intended to be collected in order to help foster that public trust. So right now I have DOH did a great little video, I think, in terms of some of the legal basis for contact tracing and the information they're collecting. So Angela, can you go ahead and play this video? It's less than 5 minutes.
Hello, my name is Maayan Simkis, and I am an epidemiologist at the Washington State Department of Health. In this brief video, I will review the legal basis of contact tracing and other public health interventions in the context of COVID-19. By the end of this video, you should be able to describe the legal basis of public health interventions and explain 3 criteria for the legitimacy of public health interventions. COVID-19 has brought many unique challenges to our communities. Most of us have never experienced such a broad community use of physical distancing, quarantine, and isolation in our lifetimes. Let's begin with the straightforward question. In the United States, is there a legal basis for public health interventions, such as contact tracing and quarantine and isolation? Yes. In both the U.S. Constitution and individual state constitutions, there is legal basis for protecting the welfare of the public. However, it is important that these interventions meet 3 essential criteria. These criteria ensure that public health interventions designed to benefit the overall health of the public are balanced with individual rights to privacy and autonomy. The criteria include that the intervention must be respectful of individuals and their rights. The intervention must benefit all of society. And finally, the intervention must be a balance between the benefits to society and the limitations placed on the rights of individuals. Let's consider COVID-19 and what public health agencies are doing to stop the spread of the disease. COVID-19 is a novel disease that is rapidly spreading across the globe. In Washington state, the first case of COVID-19 was identified in January of 2020. The disease is spread person to person and can be fatal. There are no known vaccines or treatments, and testing is limited. As a public health leader, the objective is to stop the spread of the disease and help protect the health of the public. The key tools used to respond to ongoing spread of communicable diseases are to limit gatherings of people, conduct case investigations and contact tracing, and use quarantine and isolation as needed. All 3 of these interventions reduce the risk to the public for contracting COVID-19. If individuals who test positive isolate at home and their contacts quarantine appropriately, they limit the number of others exposed to the virus. While individuals' personal rights may be affected when they're instructed to isolate or quarantine, they are being asked to do so to ensure the broader well-being of the public. Case investigation and contact tracing are what make quarantine and isolation possible. Without these tools, we cannot identify the people who need to be instructed to stay home. Without these actions, there is a clear, measurable, and severe risk to the public. Given the severity of the disease and how easily it moves between people, there is justification for somewhat limiting the personal rights of individuals in order to help protect the whole. In other words, the benefits to society and the limited harms caused by contact tracing and related public health guidance for quarantine and isolation outweigh the costs to individuals. That said, some individuals may be more affected than others, including by financial hardship, limited access to food, or no place to isolate from others. It is the role of local government and public health agencies to communicate with their citizens and help ensure they receive the support they need to safely follow public health guidance. In summary, case investigation and contact tracing are legal and essential public health interventions when responding to communicable disease outbreaks. As long as they balance the benefits to the public overall with the rights of individuals to privacy and autonomy, then these tools can be implemented to help protect public health. In concert with quarantine and isolation guidance, contact tracing efforts will help our communities to stop the spread of COVID-19. Thank you for watching.
Thanks, Angela. So I think that video helps kind of go over a lot of the concepts I've been talking in a very succinct way in terms of some of the tension between public health and privacy. And that actually brings me to the next section where I'm going to talk about some of the exposure notification app data issues that have been receiving national and international attention. And then I'm going to go into a little bit about some of the debate over centralization versus decentralization that's gotten a lot of attention. So the next slide is just a whole bunch of ripped from the headlines. This there are probably hundreds of articles you could read online about data collection and apps and what's going on in the world in terms of the use of technology and smart devices in terms of trying to combat the disease. So these are just some of the ones that I pulled recently. So I will point out that Washington State is actually using the Apple Google API, and that's I'm going to go into what that is a little bit. And then just talking about in terms of Norway actually suspended the use of their virus tracing app due to privacy concerns from the European data regulator. And another article that I want to talk about specifically is the one in terms of the attorney generals asking Apple and Google to serve the public health purpose. So that's the next slide. It's just a snapshot of the letter from the National Association of Attorney Generals. 38 different states have urged Google and Apple to take action regarding the apps on their platforms. And they want them to make sure that they're verifying that any apps that are on their platforms are actually have an affiliation with a public health authority, hospital, or university, or some sort of reputable academic institution in terms of the data collection for COVID-19 contact tracing. But really, it's exposure notification is what we're talking about. They want them to remove any apps that don't meet the above criteria in terms of public health authority affiliation, and then also pledge to remove any of the apps after the national emergency ends. So that is also available online if anybody's interested in reading the letter. I will point out that Washington State did not sign this letter. Next slide. So the exposure notification apps, something to understand is that the Apple Google API is meant to be used as a way to develop an app. So Apple and Google are not actually creating the apps. They have just made their API available to app developers. And so the API is being used by public health authorities worldwide, and the apps are use Bluetooth proximity information to send notifications on exposures. So with next steps of what to do. So the apps are really intended to help people get information about what to do if they were potentially exposed. And some of the information collected, if you go to the next slide, is an example of how the proximity data that's using the Google Apple API works. So really it's just meant to two people that may be near each other. So the example they have here are Alice and Bob, A and B, and they sit next to each other on a bench, or say you're in a bus or something with a lot of other people. If anybody has an app that is downloaded that uses this interface, their devices are actually pinging each other in the background and exchanging a type of key that can't be linked to the individual or the device, but they're exchanging these keys with each other through the devices that share whether or not they've been near each other. And so then Bob has tested positive, and the way I've understood that the apps are going to be working is it's up to Bob himself to then put in information into the app to say he has a positive test. And then the app goes through the keys and finds any keys that he may have been exposed to, and then there's a matching that occurs, and then there's a notification that goes to the person that potentially was exposed to somebody that they may not have known they were exposed to. And so this way, then Alice is able to find out she's been near somebody, and then she can monitor her symptoms and decide what to do. And a lot of the app is really having to help individuals, essentially telling them to contact public health authorities or their providers if they've been exposed. There's not supposed to be any type of identifiable information in terms of what's being exchanged and what's being provided to the individuals when they receive the notifications. So some of the debate when I'm talking about a centralization or decentralization approach is how the information about the keys is gathered and the individuals. So if you could go to the next slide, Angela.
So Katie, are you seeing me on the current slide deck?
Yes.
Are you seeing that I'm on the current slide deck? Okay.
Yeah. Yes. So the next slide is this centralization or decentralization approach. So the debate has been whether or not there should be a centralized server, and a lot of European countries, I think France and Germany and UK, had looked at centralized servers in terms of collecting and matching information. And the Google Apple API requires that geolocation information is not collected and that it's decentralized. And so some of the issues and tension that has been raised in a lot of the articles I showed earlier has been whether or not if there should be a centralized server. And so Google and Apple have made it very clear that they're not, that their API is not to be used in a centralized manner or collect geolocation information. In fact, the API is disabled in terms of using geolocation data. And so some of the European Union countries that originally went for the centralized model had found that their apps are not working very well because the API that Google and Apple developed with their operating systems allows the exchange of the proximity information to occur even when the device is sort of asleep in your pocket versus being actively out of your pocket and you looking at your device. And so that's where some of the technological issues have really hampered a use in terms of the centralization model, because it drains the battery life in a way that the Google Apple API doesn't drain the battery life. And so there's challenges in terms of the data exchange and use in terms of people downloading the app and that type of a thing. It just hasn't worked out as well to follow the centralized model for a lot of those countries that have tried. And there's been some frustration from the countries and public health officials sort of demanding that Google and Apple share more of their information in terms of how their operating systems work so that they can develop apps in a more centralized way. But so far, Google and Apple have declined to change the privacy-centric model that they're using. So the data collected by the exposure notification apps depends on the app. And I will say that some are using geolocation data. There was one, I think it was in North Dakota, and that was one of the headlines I pulled. It was a very early app that actually did share geolocation data with third parties. I think, and people may have even been advertised to based on that. And so everybody else is trying to, learn from those lessons in terms of not violating people's privacy or sharing with third parties in a way that people aren't aware is occurring. But the apps at least are collecting sometimes the name of the individual and then the symptom and health information that they're checking on symptoms. There's the positive COVID diagnosis. So some of the discussion about some of the challenges with these apps is whether if people have to report themselves whether or not they have a positive test, that somebody could falsely report that they have a positive test. And so there's talks of giving people actual PIN numbers or something to confirm that they have a positive test, so that when they're reporting, they're not making up, creating false positives or false panic then for the populations if they're not actually a positive individual. And then some other of the privacy protections in the Google notification app is that the keys change every 15 minutes, and that the data is deleted either in 30 days or 60 days. There's usually a rolling deletion of the data because once after at least 14 days, I think the symptom data is not necessarily good data anymore in terms of helping people recognize they've been exposed. So some of the best practices for the data collection would include security, so implementing reasonable, sorry, I'm on the next slide, Angela. Implementing reasonable physical, administrative, and technical safeguards, ensuring individual participation, which means obtaining consent from the people who choose to use the app. And then for data minimization, collecting only the data that's actually needed to accomplish the intended purpose. And that's where the questions about geolocation data becomes an issue. And then limiting the purpose of the data to only the stated reasons for collection and not using it for secondary purposes, and deleting it when it's no longer needed, and then being transparent about what data is collected for what purposes and how it will be used and even shared or stored. So given all of the questions about the apps that have been popping up all over the world, there's been a lot of activity at the national level in terms of potential legislation. So I'm going to briefly talk about some of the federal legislation that's being considered. So next slide. So there's 3 bills right now that have been introduced at the federal level, and that's the Public Health Emergency Privacy Act, the COVID-19 Consumer Data Protection Act, and then the Exposure Notification Privacy Act. So just briefly, next slide, the Public Health Emergency Privacy Act and the COVID-19 Consumer Data Protection Act are actually partisan bills. The PHEPA is a Democratic bill that has sponsors in both the House and the Senate. And the other bill is just in the Senate, and it's been introduced by Republican lawmakers. So there are some differences between the legislation, and I would point out that a lot of the parts of the Democratic bill gets into some of what has been contentious issues even in our own state in terms of enforcement, which includes the bill includes a private right of action for individuals, and it also includes a non-preemption clause, which means that state laws could actually be more restrictive than the federal law. So those have been some of the sticking points for the Washington Privacy Act, and then also at the federal level in terms of other privacy legislation being considered. I would also point out that the Democratic bill applies to more expansively than the Republican bill and would apply to employee symptom data, where the Republican bill excludes employee symptom data. And so that includes information that employers are collected in terms of their employee workplaces and sort of the symptom questions that are being asked. But the other bill that's been introduced is actually from Senator Cantwell. That's the next slide. And this is actually a bipartisan bill, and it's the Exposure Notification Privacy Act. And things that are specific to this one is it's really targeted toward the apps. And it's been sponsored by Senator Cantwell, Senator Cassidy, who I believe is a doctor and a Republican lawmaker in Louisiana, and Senator Klobuchar. And so this is really specific to the technology, but it really gets into some of the parts of the best practices principles that we were talking about earlier in terms of security, requiring that it be voluntary, I think is interesting as well, because I think there's a concern that's been shared that it's possible that employers or academic institutions could require people to download the app in order to, return to work or return to school. And so I think this law is meant to make sure that people don't have to use it unless they actually want to. So it can't be required. So, and then it also has some enforcement measures as well that allow the federal and state authorities to prosecute violations and pursue some strong penalties for collecting data and using it inappropriately through these apps. So just to go briefly, I know I covered a lot of material today in a very quick way, but hopefully you learned something in terms of some of the concepts that we covered. I would be happy to field questions for what we have time for, but also if you want to contact me after this or want more information on any of the things that I've talked about today, I'd be certainly happy to follow up with you or your agencies after this presentation. So thank you very much.
So Katie, there were a couple of questions that came in. Is DOH a hybrid entity under HIPAA?
Yes.
Okay. And then Michael had a question, but I think you answered it. It was about verifying the person inputting a positive test result into the API is actually positive. And I think you covered that on one of the slides after he posed the question.
Okay.
Right. Yeah.
And I'll just briefly touch on the DOH hybrid issue again. So there's only one small program that I think at DOH that's actually required to comply with HIPAA, and I can't remember the name of the program at this moment, but it's a very discrete program within DOH. Otherwise, the most of the agency is not subject to the HIPAA regulations. Oh, newborn. Thank you, Judy. It's the newborn screening program. Okay. So that's everything I had for today. And Judy, if you're here, don't want to put you on the spot, but if there's anything else that I should have clarified better or didn't touch on correctly, then I would definitely welcome you to weigh in. So, but I also want to thank DOH as well in terms of they're helping me understand this and reviewing the slides as well.
So Katie, there is one last thing here from Kathleen Sullivan. Can you say more about what issues are being studied by the state in connection with Common Circle?
So I would say the privacy issues are definitely being studied by the state. The Common Circle app is being developed with UW, Microsoft, and with some input from DOH and other epidemiologists and computer scientists. So part of what's being looked at as well, and this is part of the conversation, is that there's the part where the Google Apple API does not allow the geolocation data to be collected. And I think I mentioned there's some utility in that data for public health officials. And so what I think is being really closely looked at and considered is if there's a way to help people remember where they might have been without sharing that data. So that gets into sort of some of the contact tracing memory jogging questions that we were talking about, where possibly where the information is not necessarily shared with others, but there's a way for individuals to better track where they might have been over 2 weeks, time, and they end up with a positive test, so that there's a more accurate way to figure out where exposures may have occurred. So it looks like we're at the top of the hour. So I just want to say thanks to everybody who participated. And like I said, I'm happy to field more questions either via email or give me a call if you want to discuss anything we talked about today. So thanks, everybody. Have a great day.